Your first patient of the day is a 3-month-old baby whose parents say stopped breathing. And you wonder, is this serious? Am I supposed to run to the room? What is wrong? What is going on?
And then your resident asks you for some advice because they're wondering what they have to do to get their ABEM certification and what is this new certification exam. And you ask yourself, there's a new certification exam? I better read up on that.
In this episode of Critical Decisions in Emergency Medicine, we will talk about evaluating and managing BRUE in pediatric patients, specifically risk stratification and further workup.
We will also talk about the ABEM initial certification process for our trainees, including more details about this new certification exam.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices in Florida and all over the world.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the April 2026 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features such as Critical ECG, Clinical Pediatrics, and Critical Image.
So for our first lesson of this issue, we have Out of the Blue, Evaluating and Managing BRUE in Pediatric Patients. Thank you to Drs. Tagliaferro and Glauser for writing this article.
Danya, let's start with definitions. What is BRUE and how serious is it?
So BRUE is short for brief, resolved, unexplained event. And what that means, it's an acute, unexpected change in the infant's respiration, appearance, or behavior that quickly resolves and after an initial medical examination cannot be explained by an underlying cause. 8% of these patients with BRUE end up actually having a serious underlying etiology, such as like seizures or apnea that has caused their episode, which basically means that they don't have actual BRUE. Now, historically, we used to call this ALTI, and I don't know if that's what you referred to it during your training as well, the earlier part of your training. An ALTI used to refer to apparent life-threatening event. And the definition for that was a little different in that they had to have some apnea, whether central or obstructive, color alteration, so they become cyanotic or pale or flushed, and a significant change in the muscle tone, such as limpness, and a choking or gagging. And by definition, it must have induced fear in the observer that the infant had died. So as you can tell, it's very ambiguous and very subjective, very vague. And that's why the AAP, the American Academy of Pediatrics, replaced this term in 2016 with the term BRUE and also added some criteria of how to take care of that. Now, keep in mind, some things were considered ALTI in the past that are no longer under the BRUE definition. So that's why it's important for us to really discuss this topic and update our understanding. Remember that there are people who use these really weird terms that we should not use at all, like near-miss sudden infant death syndrome or aborted crib death. It just sounds so dramatic, just as vague, and it doesn't help us actually care for our patients. So BRUE is the way to go.
That makes sense. Then let's talk a little bit about when one of these patients come into the ED. Do all of these patients require a workup?
So by definition, it's quite scary to see something like this. The patient had a change in color, had absent, decreased, or irregular breathing, a marked change in tone, whether hyper or hypotonia, and some like altered level of responsiveness. And all of these episodes are less than 20 to 30 seconds usually. By definition, they have to be asymptomatic at their presentation. Now, the whole point of us taking care of these patients is that we try to figure out if there's an underlying condition that can explain this episode, and therefore like, that they don't have actual BRUE. In order for us to figure out if somebody is low risk, they have to meet certain criteria. And this is the most important part of this whole lesson. They have to be older than 60 days. If they were preemie, they would have been born at 32 weeks or more. And at the time that you see them, they have a post-conceptional age of 45 weeks or more. It's only 1 episode of BRUE. It's less than 1 minute. They did not require CPR by a competent medical professional, and they have no concerning historical traits or physical examination findings. If your patient meets all of those criteria, then they're considered low risk.
That's really good to know. Are there other relevant history and physical findings that can help us?
So that's the tricky part. You need to take a very thorough history and physical examination in order for you to say this patient is low risk. You need to think about what are the things that this could be hiding and look for that. So, do they have risk factors for child abuse or recent illness or an injury? Have they had medications recently or access to medications that they could have overdosed on, for example? Have they been having vomiting, lethargy? Any concerns about congenital anomalies? Any concerns about family history of things like congenital diseases, metabolic disease, heart disease, and so on? And then on physical exam, you need to look for things that would concern you for non-accidental trauma. And then, of course, for sepsis or a congenital heart disease. So those are the big things that you look for. And then the most important part as well is if somebody describes apnea to you, you really need to understand what that means. Now, if the patient truly stopped breathing for more than 20 seconds, or when they stopped breathing, they had bradycardia or cyanosis, then that's considered significant apnea. And the reason that matters is because significant apnea can be caused by things like pneumonia, sepsis, meningitis, hypoglycemia, seizures, things that are really horrible. But then there are much less scary reasons that babies have apnea. I know it sounds weird. These two words should not be together, low risk and apnea. But there are things like gastroesophageal reflux, periodic breathing, breath holding spells, things that babies do that make them apneic but are not actually scary. They're just scary looking.
I presume some of those conditions you just mentioned are essentially the ruling out process we do before we define an event as BRUE.
Absolutely. Again, it's non-accidental trauma, infections, aspiration, seizures, congenital disorders, and the inborn errors of metabolism, the thing that no one outside of pediatrics understands.
So you've done a very thorough history and exam as well as risk stratification. Now what do we do?
So if they are low risk, they meet all of these low risk criteria, then the AAP advocates against testing, against routine admission, against imaging. You just observe them for 1 to 4 hours in the emergency department, monitor with continuous pulse oximetry, and possibly ECG assessment for non-sinus rhythm, things that are super obvious, like heart block, non-sinus rhythm, WPW, epsilon waves, brugada. So not the detailed understanding of a pediatric ECG. Now, if somebody does not meet those low-risk criteria, then that is when you really need to do a full workup and admit them to the hospital. The workup is going to be guided by what you uncovered with your history and exam, but it usually includes lab studies, strong consideration for LP and chest X-ray and ECG, possibly imaging as well, because you're looking for sepsis and non-accidental trauma, like your two really, really big things here.
That makes sense as well. It definitely can be quite a dramatic presentation, and the caregivers for these infants can, I suspect, be quite anxious. How do we counsel them?
Well, you're absolutely right. It's a very scary thing for caregivers to look at. It's really important to do shared decision making and arrange for outpatient management. It may be helpful to create a pictorial shared decision-making tool, like the ones we use for closed head injury, or I don't know if you remember, Wendy, when the heart score first came out, we would use this pictorial thing where say, well, these are 100 people with this problem with your presentation. Only one of them is going to have this issue. And sometimes that can really help drive the point that their child is okay and can go home with appropriate follow-up. And of course, we have to give them very clear instructions on when to come back.
Got it. Is there anything else we need to know about?
Well, the article goes into details about non-accidental trauma, risk factors, and protective factors for child abuse and so on. Definitely an interesting read and a refresher for an important cause for this presentation.
Well, thank you, Danya, for taking us through this lesson, as well as the authors for writing it. We went through a number of very important pearls, and so please do take a look through this lesson to learn more about it. I think starting off is really the change in the definition from what we used to call ALT to a BRUE, as well as, like you mentioned, most importantly, risk stratifying these patients. That will really drive how you work them up or not, because if they're low risk, then that can be quite reassuring.
So for our next feature, the critical ECG, it reviews when to suspect an acute myocardial infarction when a patient has a left bundle branch block, specifically Scarposa criteria. A great refresher for an important pitfall when interpreting patients' ECGs when they have an underlying left bundle. So take a look.
Moving on to our clinical pediatrics this month, it is a case of a 3-week-old female coming in with a rash, and it is malodorous with a yellow discharge. And when you examine her, there's also a lot of erythema and desquamation. So you're definitely suspicious for staph scalded skin syndrome.
Now, we've discussed a range of pediatric febrile rashes last month, and this is one of the scary ones. SSSS, which is a lot easier than staph scalded skin syndrome. What's up with all these tongue twisters, Wendy? Between this and the full left bundle, it's too much right now. So it's a potentially life-threatening infection caused by Staph aureus. And what happens is that they're sloughing of the skin in the presence of epidermolytic exotoxin. It commonly affects children younger than 2 and typically manifests in the skin folds of the groin, neck, arm, leg, and axilla, which is why it's really important to know what it looks like, because you can be misguided and think that this is just one of the regular fold rashes that babies get. Now, symptom development can vary. However, once the rash appears, it tends to be rapidly spreading, developing into blistering and peeling that exposes erythematous, tender skin. Topical antibiotics alone are insufficient because the oxytocin spreads rapidly through the bloodstream, and that's why patients need IV antibiotics as well as fluid and nutritional support if needed. Patients with severe systemic involvement and significant areas of skin sloughing should be also admitted to a burn unit, and the caregivers should undergo nasal swab testing for Staph aureus toxin, and if positive, they should be treated with antibiotics as well.
I did not know that.
Our literature review this month is an article by Robin et al. That talks about protecting frontline workers, strategies for preventing and mitigating violence in the emergency department. That was published in Annals in 2025.
Unfortunately, violence in the healthcare setting, and especially the emergency department, is a under-recognized occupational hazard that affects all of us. And this can involve verbal threats, physical assault, or even the use of weapons. And unfortunately, the studies have also shown that up to maybe even 97% of emergency department staff have experienced verbal violence. And another study of EM residencies found that 78% of respondents experienced at least one act of physical violence. So something we definitely need to talk about. And there's a lot of important consequences. Of course, there's the risk of physical injury, psychological trauma, decreased job satisfaction, and that can all lead to worsened burnout and attrition as well. The article differentiates the fact that these violent events can be intentional or unintentional. And because of this different categorization and different underlying causes, the ways to manage them are also quite different. We need to look at more system level type of approaches to addressing this, whether it is talking about the layout and build and environment in the emergency department, including visibility and overcrowding, as well as, of course, staff training on recognition and how to de-escalate, or even learning about self-defense training that could be offered to staff. And don't forget that another major part of this is looking at an institution's culture, because having more formalized policies and procedures for reporting workplace violence events can help staff in improving the perception that this is an aspect of working in the emergency department that people are addressing. The article also mentions one particular tool called the STAMP tool: staring, tone, anxiety, mumbling, and pacing, which are all, I think, clinical symptoms that we recognize, but this helps provide that framework as a way for us to identify patients who may be higher risk in displaying or having violent interactions.
Well, thank you, Wendy, for reviewing this article. Definitely an important topic for emergency physicians and an unfortunate phenomenon that keeps on increasing. Moving on to our critical procedure this month, it is one of the most critical procedures that we do in medicine. And people think, wait, is that intubation? Is that central lines? No, it is obtaining informed consent. And what's important is that we need to assess a patient's capacity And that would be specific to each procedure or medical decision, because capacity 1 is specific to what we're talking about. So they can have capacity for something simple but not complex, and also can change over time. The consent should include the procedure or the care that we're recommending, along with its alternatives, its risks and benefits, and the reason for the recommended plan. And if there are any conflicts of interest, they should be disclosed. Now, of course, during true medical emergencies, when obtaining the consent would delay necessary life-saving treatment, then at that point we can move on without that consent with the assumption that it's implied since they presented to our emergency department, as long as they don't have written documentation and no reason to believe they would decline that.
Some other considerations are that some barriers that may appear to be challenges in a patient's ability to make medical decisions, whether it's language barriers, a lower level of education, or physical impairment like hearing loss, are not truly barriers if the right support and resources are available. And as Danya mentioned, the capacity to make a decision is specific to the particular situation. And so even patients with dementia, for example, can still be capable of making certain decisions in their healthcare. One myth that I want to debunk is that there may have been previous discussions about patients in pain or receiving pain medications, and that can impair their judgment. But truly, the act of withholding pain medications so that a patient can make a medical decision without potential effects on their cognition can actually be seen as coercion.
That's a great reminder, Wendy, and definitely something that we need to think about when we are doing this most critical procedure in emergency medicine. So for our critical cases in orthopedics and trauma, what do we have this month?
It's a 23-year-old man with right lower leg pain. He has been training for a marathon and he's been increasing his run and is coming in with pain in his anterior tibia that you can also elicit when you palpate it.
So you think to yourself, could this really be a broken bone? No, it's not. There are no deformities. But guess what? It is a tibial stress fracture. Now that accounts for nearly 1/2 of all athletic stress injuries. But the anterior cortex variant in particular is relatively rare, which is what this patient has. And if you take a look at the x-rays, quite interesting. This happens to high impact athletes, and nutritional deficiencies can also play a role. Frequently, a palpable thickened nodule, which represents a hypertrophic periosteal response, can be felt. One way to diagnose this is the unilateral hop test, exactly what it sounds like, or the heel percussion test. X-rays would show a horizontal radiolucent fissure, but MRI is the gold standard, obviously, as an outpatient. Now, because these fractures exist on the tension side of the bone, patients should be strictly non-weight bearing and be promptly referred to an orthopedic surgeon or a primary care sports medicine specialist for further management. Moving on to our critical image this month, it's a 74-year-old man presenting with bradycardia, and EMS was unable to obtain IV access. He was hypotensive, his pulse was 23, respiratory rate is 9, O2 75%, GCS is 3, he has agonal respirations. I'm getting tachycardic and sweaty talking about this. So transcutaneous pacing is initiated, and then the transvenous pacemaker is inserted through a right IJ without electrical capture. And they withdraw the electrode by around 20 centimeters and still no electrical capture. They advance it again for 15 centimeters, and then electrical capture happens. So they get a chest x-ray to try to figure out what was going on.
Whew, thank goodness it finally worked. Now we can of course place the transvenous pacemaker either by using the landmark technique, ECG guidance, or with imaging. I think most of us probably don't have fluoroscopy readily available, but you could use our serial chest x-ray to help, or even point-of-care ultrasound. Now, one consideration with the use of x-rays is that you can put the x-ray detector behind the patient throughout the procedure, and that may not end up contaminating your sterile field. You just have to have it in place already before you prep your sterile field.
What a great tip.
Yeah. Now, in terms of one question that may arise is, of course, the potential radiation exposure to you as the clinician placing the transvenous pacemaker. But recall that X-ray radiation, one X-ray is equivalent to 10 days of background radiation we get on Earth. And so by stepping back away from the field, that can reduce your exposure significantly. The particular images that I recommend for us to take a look at is that we're used to looking at placement of IJ lines, but specifically for a transvenous pacemaker through the IJ approach, you're looking at getting the tip of the electrode near to the right ventricle. And that is approximately 3.4 vertebral body units below the carina. What is a vertebral body units? Well, it is a vertebral body height. So instead of having to measure it out by a ruler, you can just use the vertebral body as another estimate.
I'm all about simplifying things. This is great. So moving on to our second lesson this month, it's about ABEM initial certification. Thank you to Drs. Borges, Feldhaus, and Finnell for writing this article. Wendy, our board certification process recently changed. What do our residents need to know about getting their initial ABEM certification?
Well, in terms of timeline, they definitely need to start this process in their final year of their training. And you're looking at applying for initial certification from the May to October time window. But if a resident is graduating after November 1st, then they are eligible to apply the following calendar year. So their timeline may be different. There are 3 parts to it because after your application, then the second part is passing the qualifying exam, which is the computer-based multiple choice test. That is offered usually up to 2 weeks each fall. And this is the 8 hours of test at one of the computer testing centers across the United States and Canada. It is important for our trainees to definitely review their eligibility and the policy around it on the ABEM website, especially if there is going to be any delay in sitting for their qualifying exam. And then the final part is the certification exam, which is what has changed. What we used to call as the oral exam is now the certifying exam. And to be able to perform this part, you have to first, of course, pass your qualifying exam, and you need to have an active, unrestricted license to practice medicine in the United States, territories, or Canada.
So I know you touched on this, but what exactly is the difference between this new certifying exam and the previous oral exam?
I think the oral exam that we all took was one where we were tested on essentially scenarios, right? Patient scenarios to walk through what we do for them. But this was retired in 2025, and the new certification exam started this year. And this is conducted in person at the ABEM Assessment, Innovation, Measurement, and Excellence Center in Raleigh, North Carolina. And now it also incorporates the simulation as well as standardized patients to really add more interactive nature to this particular patient scenarios. There are 10 cases, some of which are guided scenarios to assess the physician's ability to prioritize their patient care, respond to unanticipated clinical developments. There are also some stations that are focused on professionalism and technical proficiency. And then for the technical skills part, there's even ultrasound cases with live models. So definitely very immersive and interactive.
Got it. So what else is different in this updated process?
There's also an update to the program director attestation for a trainee to be eligible to proceed with all their certification process. So in the past, the program directors would attest to successful completion of their training, but now it is more detailed attestation to actual competencies.
Got it. So what if one runs out of time in their 5-year board eligible period?
Well, and if an individual passed their qualifying exam, but not their certifying exam, then they would need to complete LLSA and CME to extend their eligibility. And if that further expires, then they actually need to complete an ABEM approved physician re-eligibility program or PrEP. Definitely take a look at the ABEM website for more details.
Well, thank you, Wendy, for this great review. And thank you for the authors for writing this article that really clarifies the difference between the current process for this new certifying examination, both of how the examination actually works, what are the requirements, what is the eligibility requirement, and how to navigate that when compared with the traditional certifying exam, oral examination, and prior rules. Definitely worth a read.
For our drug box this month, it is sugammadex. As we know, it can be used to reverse neuromuscular blockade when you've given rocuronium or vecuronium, and it does so by actually encapsulating the drug in plasma. Dosing, though, really should be based on the depth of neuromuscular blockade, and you need to assess this by train of 4. You don't just want to guesstimate how much to give, because there's actually a risk of anaphylaxis that increases with higher doses. So we don't want to give more than what's necessary. Another thing to note is that there have been cases of severe bradycardic and cardiac arrest. And so we do want to, of course, monitor these patients very carefully.
Great review of a drug that causes actually a lot of contention still when it comes up. And last but not least, our Tox Box this month is dimethoate toxicity, which is a highly toxic organic phosphorus compound that is used as an insecticide or acaricide on crops. I don't even know what that means. And it causes cholinergic excess, which leads to death from respiratory complications. I know what that means, and that's the part that matters. Now, if patients are coming in, they're really hypotensive, like their systolic is below 80, then the case fatality rate is more than 80%. And if you're able to measure their butyryl cholinesterase levels or their dimethoate concentration, then there are levels that are very specific for death. Focusing on what we can actually do, atropine, just double the dose. So basically start with 2, then give 4, then give 8, and so on, targeting clear lungs, a heart rate above 80, and a systolic pressure above 90. As soon as you get your hands on some pralidoxime, then give them 30 milligrams per kilo as a bolus, and then an infusion of 8 milligrams per kilo per hour. Anybody who requires more than 3 milligrams of atropine needs to go and hang out in the ICU. That is not a floor patient.
Scary stuff.
Well, thank you, Wendy, for taking the time to go through this issue with me. I've learned a lot. Our dear listeners, I hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decisions publication and our podcast always informative, often enlightening, and never boring.
Reach out to us on our social media. My handle on Instagram is at Dr. Danya Khoujah.
Mine is at Dr. Wendy Chang.
And until next month,
bye-bye.